Okay, shall we start and then people can join as we go along? Good morning, everybody. Welcome to the Mental Health Network of the Faculty of Homeless and Inclusion Health. My name's Jenny Drive. I think I've met lots of people here. I'm the advisor for homeless and mental health in the College of Psychiatrists and a consultant psychiatrist in South London and Maudsley in South London. It's very cold. I hope everybody's keeping warm. It's a sort of time of year when our job goes from being a pleasure to do outreach to being absolutely miserable. So I know there's bad weather expected. I hope everyone's got waterproof shoes. We've got a couple of speakers today talking about counselling through COVID and how to keep a specialist service going through the pandemic, which I'm sure that everyone will have lots of things to say about. So please keep questions coming in the chat, and we should have lots of time for questions at the end. We've also got Sophie Quena talking about, actually, do you know what? I can't remember what Sophie's talking about, so she can tell us when we get there, or I will. The meeting this morning's being recorded, so you are being recorded now. If you're not happy with that, let me know so that we can circulate the minutes afterwards. And I had one more thing to say. Oh, put yourself on mute, please, if you're not talking. Otherwise, you get lit up like a Christmas tree with any background noise that you make, which can be unfortunate. So I will stop talking and hand over to John Connolly from the Westminster Homeless Health Team.
Hello, everybody. Yes, I lead a small counselling service in Westminster, and I will be sharing some slides with you. If I can find them again. Gosh, where have they got to? Let me have a look. Oh, right. Okay. Right, so yes, as Jenny told us, how do we maintain services through a pandemic? I'm just going to talk about 4 different sections, give you a quick background context about Westminster, how my service was delivered pre-COVID, how it was delivered during COVID, and some questions I raised for discussion regarding post-COVID. So London, as we all know, accounts for roughly 27% of the total number of people sleeping rough in England. And Westminster accounts for nearly 10% for England and 34% for London. Hence, the presence of several specialist services in Westminster, including mine, which is the Westminster Homeless Health Counselling Service. We deliver our counselling, our support, our psychotherapy in 3 homeless day centres and 2 specialist homeless GP surgeries. Our referral sources are abroad. They're from the homeless health nurses who also provide outreach, from the mental health teams, IAPT, mental health hospitals, hostels, day centres, and also, of course, self-referrals. So we're a bit of a catch-all service. Our initial aim was to remoralize people, which basically was to try and relieve people's immediate distress and kickstart their basic coping resources. But as we all know, homelessness presents extraordinary challenges. The challenges of marginalization, the clinical challenges, and the systemic challenges. Marginalization, there are physical needs as well as material needs. People have multiple appointments to attend, which can be very stressful and can confuse people. Clinically, as we all know, there's trimorbidity. There's no simple presentation. And of course, we have compound and complex trauma, as well as a lack of trust and emotional deregulation. The asterisks are in Appendix 1, where Appendix 1 explains these concepts a little bit more. And of course, then there's the systemic issues, as we all know, whereby presenting at services can re-trigger trauma reactions. No recourse to public funds, high referral criteria, and of course, very long waiting lists. So we found ourselves not only having to remediate, but to remediate and to rehabilitate, which was quite a challenge. And how on earth could we do that? So we had to devise a service that provided an enhanced service. And we developed a pre-treatment therapy approach, which is based on pre-treatment, which is Jay Levy's work in the States, trauma recovery stages, attachment, and support and advice signposting. And we delivered that via drop-ins, one-to-one drop-ins, where people could just walk in, drop in groups, and more structured counselling appointments. And also we provided follow-up support, especially transition management. When people were moved out of borough, for example, we would continue to support them 6 months maybe to make sure that they engaged with their local services and they didn't relapse and disappear off the radar again. So that was this was before COVID, and we offered mainly face-to-face interactions. Now, of course, during COVID, as we all experienced in one form or another, a lot of services closed down. So the day centres, specialist GPs, also the shops and also the public toilets became extremely difficult to access, certainly for some of our patients at our service. And people were struggling to access basic needs, food, washing facilities, sleeping bags, because all of our services had closed. Obviously, this led to high levels of anxiety and high levels of despair. And the mental health services were overwhelmed, and there were extremely long waiting times. I was told somebody waiting 2 hours to get through to SPA, for example. We offered remote support mainly via telephone. The online take-up was extremely low, mainly because of difficulties accessing the equipment because of facilities being closed. Even telephone support had its difficulties. People had issues with reception. People had issues keeping the batteries charged. Again, because of facilities being closed. Because of the pressures people were under, we saw the challenges, physical, clinical, as well as systemic. And here, of course, we've got the extra pandemic challenge. Because of all of those pressures, people could only tolerate very limited conversations. We used to offer 50-minute sessions pre-COVID. On the phone, on average, we found it was down to 15, 20 minutes that people could not tolerate longer than that. And also people's concerns were on basic survival needs. So the conversation was very much about supporting people, advising people, signposted people. The impact on the counselling service, we had a surge in referrals, a massive surge, which put us all under quite a lot of pressure. Of course, the intensity of the conversations was very much increased. Anxiety levels gone sky high. This impacted our work-life boundaries. So most of the staff at the counselling service certainly did not take any Christmas leave last Christmas because we felt that the need was so high and so desperate. And it impacted our work-life boundaries. Because we were offering phone support, we were dealing with people's distress in our home, private space and environment, and in our ear. So the distress was no longer removed. It was very, very close to us. And this obviously had implications for how we dealt with that, how we processed that, both mentally and physically. And of course, like everybody in the country, if not the world, we had to deal with our own issues about COVID. So I had staff who actually caught COVID, and of course, who knew people who'd caught COVID. So as a team, we had our own personal issues and our own distress to manage, as well as managing and supporting our patients' distress. Our response to that was to have weekly team meetings. We used to have them fortnightly, pre-COVID. These were increased to weekly. I made myself available for support anytime. And we also set up a helpline for CLCH NHS Trust, together with other psychologists in the trust. And it was a wonderful surprise to discover that, in fact, there was something like 20 mental health professionals working in the trust. And none of us had had any idea that we were all in the same trust. We were all in very small, disparate services in different boroughs. So that certainly made us aware of each other. And we also provided a helpline for certainly one of the specialist GP surgeries for their staff, to support their staff, because frontline staff, as we know, were very impacted by COVID. So the response from the housing community and the state. So as we know, a lot of people were rehoused in hotels. Some people were offered wraparound support service referrals, and some people were rehoused. In the longer term, questions began to emerge about the adequacy of rehousing, the withdrawal of the wraparound support, leading, in our experience, to a silent, invisible deterioration of that person's mental health. I will be presenting a case study that illustrates some of these issues. So, for example, in March 2020, a middle-aged Arabic-speaking woman who did not speak English and could not understand English, so I could only communicate with her via interpreter, was referred to me by a GP, and she'd been on the streets several years, at least 4 years. She was avoiding all public places because of COVID. All the shops were closed. She was struggling to find food. She was not on chain, so she was unverified. So I gave her the StreetLink number. She tried contacting them several times until eventually I discovered that she'd recorded the wrong number. Whether that was via stress, whether that was via the interpreter, who knows? Anyway, it wasn't until April that she made contact with StreetLink. So that was a whole month that had gone by. Mid-April, she was very tired, but she'd sourced a reliable food supply, and she'd also spoken with the outreach teams. And she was rehoused in a hotel, 20th of March, and she was very pleased. And I could tell on the phone, she sounded much more relaxed. There was joy in her voice. After 4 years out on the street, it was absolute luxury for her to have her own private space and bathroom. But the anxiety was there still, because she'd heard she might have to move. And she usually spent her days in the park, again, avoiding people. She accepted a final rehousing offer after having viewed two and turned them down. She felt she had to accept a very small studio in a basement with no real natural daylight. And she suffered from PTSD as well. And this was one of the issues about the adequacy of rehousing, because the basement reminded her of her imprisonment and her prison experiences, which is why she came to this country as a refugee. and it made her PTSD a lot worse. In fact, I referred her to the trauma stress clinic because of that. She was informed that there was a 6-month waiting list, and suddenly her memory began to deteriorate. So she no longer knew who I was. I was calling her on a weekly basis, on average 20 minutes, sometimes 30 minutes, and she no longer knew who I was. Now, it emerged that in December, noisy, intimidating neighbors had moved in, which could have possibly led to an increase in her PTSD, maybe dissociation, hence her memory issues. She was invited in for a trauma assessment at the clinic. She was turned down because of her memory issues. They felt that they could not help her given her lack of retention. And she was referred for a scan eventually in February. She had a mental health assessment in May, where it was believed she was suffering from severe depression. The scan eventually showed in June that she had no brain deterioration, and liaison with social services and referral to community mental health team occurred. Social services turned her down, but referred her to floating support. And in October, so fairly recently, she was visited at home by floating support, and they are helping her to rehouse in more suitable accommodation. And I'm continuing to support her via telephone and to monitor her, how she's doing. Is she deteriorating? Is she remaining stable? So that was a very typical case study of some of the more extreme challenges that some of us come across. I know that there's even more extreme cases. So the question is regarding post-COVID. As we know from the news, the cost of living is going up. Already the special benefits have been withdrawn. There's an increase in rent arrears. It's now legally possible to evict people again. And of course, people's resilience over the last 18 months, 2 years, has been weakened. In terms of my service, we're very much at the moment delivering a hybrid service. So some of us are still home-based because we're very dependent on policy of the day centres or the GP surgeries because we use their premises. So depending on our hosts, some of us are resuming face-to-face. If the rooms are large, if there's natural airflows, if they're large enough to have one-way systems, etc. But some of them aren't. So some of us are home-based. And of course, yes, staff are tired. So a lot of questions to think about. That's the appendix. I won't take you through it. I'm happy to have all of this circulated, to have my slides circulated to people if they want. Yeah, so that's me. That's me done.
Thank you, John. It's really good to be reminded of those times, even though they were so recent, and how frightening they were in the first few days of not knowing what was going to happen. I see Nigel's got his hand up. But I was just going to ask, John, did you say in that case study that the lady wasn't taken on by the CMHT with her severe depression?
No, she wasn't, because of the memory problems. I think people really wanted to get down to the nature of her memory problems first of all. Yes. She wasn't taken on by the stress clinic either, which makes sense because, you know, she doesn't even remember who I am from week to week. So I had to explain each time I speak to her. I said, look, you know, I'm calling you from your GP surgery, etc. And she's very grateful. She said, oh, thank you, you know. It's,
There's a whole other
yes.
discussion to be have about the lack of services, I think.
Well, they were overwhelmed. That's my sense.
Yeah.
Yeah.
Yes, I can imagine. I think what we'll do, well, Nigel, do you want to come in?
I was just going to ask a question, but if you want to keep them for the end, that's fine as well.
Oh, well, I was going to say, shall we hear from both Steve and John back to answer questions? Because Steve is going to tell us about his.
I think I'm going to have to leave soon. I've got.
Oh, okay. In that case, we'll do your
session very
questions
soon,
now.
I'm afraid. So
Okay,
I can't
no
stay
worries.
the duration. You know.
So in that case, if
Let-
people have questions, if you could pop your hands up or write in the chat, that would be great. So Nigel.
Yeah, I think we're a small enough group to be able to wave our hands. I was just struck by the concept of toxic help in that slide, which I think I know what it means, and it certainly sounds like something I've seen. Could you just expand on that a little bit?
Yes, toxic help is there's often there are histories of people having been placed in services like care homes, for example, or having been referred to a psychologist or to a professional, expecting to be helped, but the help has actually made them worse. So, for example, in care homes, they might have been abused, or the professional might have blamed them for their intervention failing. So they've left the treatment, the care, feeling worse, so losing more hope, having more distrust for the authorities or the establishment and its representatives, including health workers, unfortunately, and also shouldering the blame for the failure of the intervention. So rather than the professional contextualizing the failure by maybe the intervention wasn't right, maybe the timing wasn't right, maybe the circumstances the person was receiving the intervention weren't right, maybe they were in survival mode, maybe they couldn't retain what was being said in the sessions because they were too stressed. All of these very micro elements of communication and the retention of communication and understanding of information were not explored. They're not explored. So the patient leaves feeling, I'm untreatable. I can't be helped. That's what toxic help means, that people turn for help to designated people and they actually are made to feel worse.
Thank you. That's really helpful.
Mm-hmm. Yeah, it's very evocative. Everything that you've said, really. Did you manage to? Did you give people phones? Because a lot of our clients don't have phones, and then we gave phones to a lot of people, and then they vanished.
Yeah, the day centres, because we're hosted, you see, by homeless day centres and by specialist GP surgeries in Westminster. So they made accessible mobiles, cheap mobile phones for patients who didn't have any. But then there was the extra issue of charging, of keeping the batteries charged, which that was. But obviously, as the pandemic progressed and as as society responded, it became easier. I mean, there was that initial emergency phase, wasn't there? And then it kind of stabilized and things kind of eased up a little bit.
Yeah, and I think really hard then to still be working from home when things have sort of got back to normal. Did you find it? How did people find it? The sort of telephone support.
It's fascinating because some people were desperate for face-to-face interaction, but not as many as I thought. Especially new referrals. It was hard. It was much harder to establish a relationship with a new referral over the phone, whereas established relationships, the transfer to phone was actually quite easy. But it was challenging. For example, the nature of a silence on the phone, of a pause. Is that a technological issue? And is it a hostile silence? Is it an anxious silence? Is it a silence where there's joint communion going on? So it's the interpretation of the different rhythms of speech or non-speech, that becomes problematic, because you can't rely on the visual body language to contextualize the linguistic micro cues. So it took a while to adapt to telephone work, sure, but you know, people did, and I think people found and are finding the telephone support very useful. But it became much more concrete. It became support rather than therapy. We were shoring up people's habitual ways of coping rather than trying to teach them new ones, because the circumstances weren't right. You know, they were under too much pressure.
Mm. Particularly
But
difficult with interpreters, I think, using telephone interpreters.
Incredibly difficult. And I suspect that maybe, you know, there was a month and a half delay in this woman accessing StreetLink, all because she'd recorded the wrong number. And I do have a question in my mind as to whether the interpreter, you know, interpreted the number wrongly, because Arabic, you know, from our system of numbers to the Arabic system of numbers, it is quite different. So it was quite, yeah. Anyway.
Quite a lot to think about, yes. I can see
Yeah,
Alex has got his hand up.
John, thank you for that. Always fascinating to listen to. I was just thinking that last point you were making, is there a risk as we rebalance back to whatever normal is going to mean, that concern that your services, that these kind of services, if they end up just dominated by phone service, where, as you said, some of the real practice of therapeutic counselling just isn't as good or doesn't happen.
Yeah.
I was thinking actually of kind of system financial risk. Will we see commissioners say we can do this much cheaper? We can crowd more appointments in. You can all do it by home. We can get back. We don't need the space. All that kind of. Is there a risk in terms of? It's always felt to me some of the kinds of services you deliver, it's intrinsic to them as the quality and the risk of COVID, yes, that we've been, we can do this cheaper, we can get less qualified people. All these people need is a 20-minute telephone support call, and there's a huge loss there. Is that a risk, do you think?
I think so. I think very much so, because it's not just about information. It's the context of information. It's the emotional context in which the information is exchanged. And there's different kinds of information. There's factual information, there's emotional information, there's evocation, all of those very subtle, early developmental modes of communicating, you know, baby, mother interaction, all of those things dependent on visual cues are incredibly healing. And that's part of the healing process, because those elements feed into the right brain. And there's a lot of neuropsychology, neuropsychoanalysis research now that's really pinpointing the micro elements of communication, which are to do with the right brain. So therapy is very much about addressing right brain functioning. And all of those elements would get lost via phone, definitely. Well, a lot of them would get lost, which would weaken the healing potential of that relationship. Because we're social creatures and we are embodied. Like, for example, silent, like the sharing of an experience, or the sharing of deep thought, or the sharing of a deep emotion between people. We feel that. We feel comfortable in the physical presence of each other. But if it's over the phone, that becomes a lot more difficult. How do you share that embodied experience over the phone? You can't. It's only through the information of words. So you lose a whole dimension to all of that, the right brain dimension.
And does that worry you? Looking forward.
It concerns me. I wouldn't say I'm worried. It's I think what concerns me more is probably the already existing thrust in the NHS for the provision of online services. Because although we have the added dimension of visual cues, it's still all very much based on image. And again, the context of the image is lacking in a way, and the embodied experience of the image is lacking. So, for example, I'm moving my hands quite a bit, but you don't see that because it's below the camera. Very simple, example.
Mm.
But the image misleads us in thinking that we are seeing all of the relevant cues, but we're not. We're missing quite a lot of those cues. And again, it's all right brain stuff. It's all emotional stuff. It's all micro communication, visual cues stuff that get missed. And those are really important. Those are really important. So yeah, I am concerned because I think online delivery of services can become an exchange of information and nothing more. No communion, no none of no empathy, for example. Much harder to convey empathy, to tolerate somebody crying in a dignified silence. All of these things can become more difficult to do online rather than in a sharing physical space together. But yeah, so I am concerned. Yeah.
Thank you.
Thank you, John. Thank you. You're very wise. It's always good to hear your reflection and things.
Thank you
as,
very much. What do you want? Okay, I have to go. I'm
I
afraid.
just could listen to you for hours with your
Okay.
wise reflections. So thank you. So you're going to go. So thanks for coming
Yeah.
and fascinating
and do
as ever.
circulate my slides, to everybody. I really don't
Yeah.
mind at all. Okay.
Thank you very much.
Bye.
Thanks, John.
Bye-bye.
Bye. So now we are moving on to Wales, which I imagine is even colder than London at the moment. Steve Masterman, who is from the Wallet, which is a pan-London, pan-Wales counselling service. Steve, over to you.
That's right. Yeah, I can confirm it is rather chilly this morning here in Wales. Yeah, firstly, thank you for the invite and for the opportunity to join the meeting today. Yeah, really pleased about that. So what I want to do is just give you an overview of the Reflections Network. As you've just pointed out, it is a pan-Wales service, and we deliver in all areas of Wales where we have a support base. So if the Wallet is in an area in Wales, we deliver the counselling service. So we have 9 counsellors on the network at the moment, and we cover 14 different areas. It's worth noting that in some of those areas, counselling is duplicated, so we may have multiple days operating in that area for our clients to access. So it's a lot bigger than just 14 areas. Our approach, or the counsellor's approach, the basis of that is we contract counsellors to the network, and they're self-employed. The approach is an integrative one. So we're not trying to teach the professional counsellors how to counsel. We're not saying you should stick to one style. It's about seeing the person, finding out about the person, and then deciding what style of counselling would suit them. The other important thing to mention is it's not time limited. Quite often we see that, okay, yes, you can have counselling 6 sessions. For us, it's not, it's not our call to make whether 6 sessions is going to be enough or not. So it's open-ended. The process isn't rushed. As I'm sure we're all aware, it takes a session or 2 to build that trust and that therapeutic relationship. Only then can, the counselling therapy begin. So the Wallet is, as Anthony has mentioned in the chat, we are Wales's largest homeless charity. We're also a PI organisation, so psychologically informed environments, and that runs right through the core of what we do. So taking you back now to March 2020, we knew something was going to happen, didn't we? Everybody felt it, and we took that preemptive step and we switched to telephone calls pretty much in the blink of an eye overnight. all our counsellors were directed to deliver by telephone call or video call. It was touched upon when John was speaking that we did have the resources whereby if a client didn't have a phone or didn't have internet access, we could provide devices. So whether that's an Android phone or a tablet, that was, we were able to do that, which was really good. At that point as well, we also set up and launched a callback service. So as the country, Wales, went into lockdown. I'm not sure if it coincided with England. It's so very different Anthony's nodding. Yeah, I'll take that cue. So as we went into lockdown, what we found were that this would be a particularly distressing time for clients. And whilst we can't make them abide by the lockdown regulations and rules, for the most part, I think clients were in temporary accommodation. They were given hotel spaces, bed and breakfast spaces, and they were at a loss, and like I say, very challenging times. So we launched a callback service. Now this consisted of all the counsellors on the network, and they were working really flexibly and gave a lot of their free time to be able to offer this service. So a client would be referred in and they would either be directed to a counsellor or a peer. So we have another project called the Boss Project, and a lot of our peer mentors volunteered for that. Now this saw clients being referred in and contact being made a lot of the time the same day. So if they were referred in the morning, they would get a call by the afternoon and they would have a chat with a counsellor or a peer on the phone, sometimes the next day. I'll just digress a sec. With the Reflections Network, our remit is that from point of referral, a client will be seen within 28 days. Now that's a little bit stretched. There are waiting lists at the minute, but they're not too extensive. That's an important point I missed there. So the callback service had a really good response, and I think we had over 100 referrals in. These were one-off events, but it opened up that door for them to be referred in to long-term counselling. Now, with the counselling sessions that were already established, it would have been really detrimental to put a pause on that. So the telephone contact or the video calls, it was a bit of a no-brainer. They were going to go ahead, no question about that. And as John spoke about at length, there was some adaptations needed. Now, a lot of our counsellors are accustomed to telephone or video counselling sessions, but all of those visual cues have been lost. I think it's important to touch upon that. So, you're looking at eye contact, you're looking at silences in the room, body language, and being able to read the room as well. If you're on the phone, you're at a bit of a loss. And I think we've all experienced that when something's come across in a way that it shouldn't have done, it's easily misconstrued. Text messages are the same. Don't get me started on that. Yeah, everybody adapted, and what we found was we had some really valuable feedback actually about that extra degree of separation, because our counselling is focused primarily upon adverse childhood experiences. So what we found was, as an organisation, people were presenting, in a particular day, on a particular day in crisis, and we were looking at those things in isolation. And what we saw there was the revolving door. It would happen again and again and again. And that's why the Reflections Network was born. We thought, right, we need to get to the root cause of why people are, making poor decisions in adulthood, and why they're so affected by adverse childhood experiences. So the opportunity to explore them was paramount for us. I've lost where I was now. I'll go back to that, no doubt. Just to give you an overview of our figures. So we launched in March 2019, and we've issued 733 first appointments. Now that translates into 6,722 hours being offered. Now that they're not all attendances. We're aware of, in any given moment, a priority list for one of our clients can change in the blink of an eye. So there are missed appointments. And all that to consider. But throughout the pandemic, that's right, I was talking about degrees of separation. Thanks for reminding me, Anthony. He kept quiet there, didn't he? So the degree of separation, I knew I'd get it back. The degree of separation happens you know, because the client is not visually known to the counsellor and vice versa. So there's no kind of opportunity for recognition. Not that our counsellors would, you know, wave at a client across the street or anything else like that. But what the feedback we had was that clients were able to disclose more freely and easier a specific really traumatic event that they may have had. So, and, you know, that would only come with, you know, telephone counselling. So that was a real valuable piece of feedback that we had, so much so that we have now kept telephone counselling as an option for our clients, which we hadn't had before, because, you know, the preferred scenario would be face-to-face in a room. So yeah, we learned from that, and, you know, I'm sure there were clients who didn't adapt to it really well, and there were exceptions whereby after the first lockdown it was identified that a particular group of clients could not access telephone or video counselling, and that would be in a domestic violence scenario. If they had the partner that was living at home with them, it was just an impossibility. So we started to restore sessions, you know, under the, you know, essential healthcare appointments. So we restored face-to-face appointments for those individuals. We do use remote venues, and we use them for predominantly for the confidentiality of the client. If we're doing it in-house in one of our residential projects and somebody comes in who is not a resident there, everybody knows why they're there. So it's about keeping the client safe. So yeah, we've just adapted. We are almost fully restored back to face-to-face counselling sessions. But the problem we've got with those remote venues is, you know, their kind of restrictions in terms of when we're not able to permit face-to-face counselling sessions because of social distancing, because of the size of the room, and because of their own guidelines that they're following. But yeah, I mean, in a nutshell, the counselling continued, and it will continue. Yeah, absolutely. So, Anthony, have you got anything to add to that? Please save me.
Steve and the network have just recently come under me, but I was a frontline manager for years before this role, and you know, we used to refer people on to the network quite a lot from our base in Aberystwyth. It's really valuable resource. We had the money as part of, it was sort of part of the Mental Health Act here in Wales when we had the money originally, and it's due to run out next March. So at the moment we're seeking additional funding because Welsh Government still haven't told us whether we're going to get it again, sort of thing. So we're, you know, and local authorities, as often happens at this time of year, each individual local authority is coming up with bits of money, aren't they, or can you do some additional counselling? So it's a very well regarded network. We've got to, you know, once we've had it, it's not something we can lose really. So we're looking to make sure we can keep it from wherever we can. You know, similar to what Steve was saying, one of the things we found with the remote counselling or just remote support, bearing in mind we got projects all over the Wales, was pretty easy to access. I say pretty easy, you know, equipment, laptops, phones, or tablets, but the issue comes from the internet access itself, doesn't it? Because you can buy dongles, but they're, you know, 4 gigs or whatever. So if somebody watches a YouTube video and does a couple of video calls, that's gone for the month, isn't it? So that for us has been the biggest problem. If somebody's in one of our residential projects, that's fine, we've got Wi-Fi there. But if it's a client out in the community, that's where we've struggled, is to give them access to the internet, not the equipment. It's the, you know, it's the actual access to the Wi-Fi and internet. And, you know, similar to what John was saying, we're an organisation, we've got 75 plus projects across Wales of all different types, and there's definitely been a split for us with staff, because residential projects, you know, nothing stopped, it's continued for the last 18 months throughout the pandemic, isn't it? So, and staff in those projects are, you know, there's burnout. It's just continued for them for the whole 18 months, isn't it? Where we've got large forgotten support projects and other types of projects and our central functions. We've been working from home. None of our staff went on furlough. We continued throughout, but there's definitely been a split between the staff that have had to remain on the, I hate the term frontline, but the ones that have been in the residential projects and out in the rough sleeping teams with the ones that have been able to work from home for a bit. So yeah, I think that's probably about it from us. I'm sure I'll think.
Thank you.
Anybody's got any questions?
It's really fascinating to hear about it. I think because I'm so London based, it's really interesting to think about things outside of London. Is it? I mean, if you're pan-London, is that rural areas and urban areas, or I don't know much about street homelessness in Wales.
Yeah, we don't deliver in London. But I knew what you meant. Yes, we do have some very kind of rural areas in Wales, and obviously we try and situate our counsellors in the best place possible so that's accessible for all. It can be a challenge. I mean, when you think that to get from one village to another, you may have to go to a major city first on public transport. So those challenges are evident. However, this is where telephone and video counselling really comes into its own, because it does make it accessible to absolutely everybody. And just to say, the criteria for counselling on the Reflections Network is, that they are engaged with wallet support and they are open on our systems. Nobody's turned away. We don't presume to think that, anybody's, problematic events are superficial. We're aware that it is the tip of the iceberg. So yeah, just wanted to kind of put that one in there. But yeah, rural areas, and we have major cities as well. So yeah.
Yeah, we're in 19 of the 22 local authorities across Wales, and we have. I mean, they've just done a rough sleeper count, and then a few local authorities have counted 0 rough sleepers, but I find that very hard to believe. But the rough sleeping is mainly focused in Cardiff, Newport, Swansea. But I'm from Aberystwyth. I managed the projects there for 6 years. I managed to work there 6 years. Aberystwyth, Ceredigion, we've reported 8 this year. There's always rough sleeping around, but yeah.
And is it bilingual counselling? Is it Welsh and English?
Yeah, we do have Welsh speakers. It's not often called for.
Is it not?
No, well, since 2019, I've never had a request, for counselling to be delivered in Welsh. But we live in hope, because we don't want the Welsh language to die.
We do have bilingual, have to provide services in bilingually. Really, it's very infrequent that we do get asked to provide stuff bilingually, but yeah, it happens occasionally.
Yeah. Nigel, your hand's up.
Yeah, thank you. I just wanted to ask a question about digital exclusion. There's a lot of thinking going on about that nationally, and there's the usual things about access to kit, and then Wi-Fi reception and data charges and getting your battery charger we're hearing about. And obviously people in residential settings, that's generally easier because there's people to facilitate that. This might be an impossible question to answer, but do you have any feeling for the people who aren't or who weren't able to access your services when things were more remote, and they couldn't go to drop-in centres? Did you get any feeling for who you weren't seeing?
We would adapt accordingly. If somebody was having, problems accessing that, we would, like we said, supply equipment. We would pay for a contract SIM for the first quarter, I think it was. And then the encouragement there would be that, if this is viable for you, you can enter this, and then it's your responsibility to maintain that. So the initial expense and outlay was ours. And our policy is do with, not for. So it's about promoting that kind of responsibility and like I say, independence there. Yeah.
As far as what you were asking, Nigel, in regards to whether we missed people, I don't think we have any sort of record of, they didn't get in touch with us and it's because they were digitally excluded. We just tried to provide whatever access we could, really. But, as Steve was alluding to there, that the equipment isn't quite such an issue. It's the access to the internet, that the data.
Yeah, and the other thing is as well, in all of our residential projects throughout the lockdown and throughout COVID, we have installed free Wi-Fi for all the residents there as well. So, okay, that's just residential, and we do have, you know, people in their own accommodation. That's a different matter altogether. But where possible, we've tried to include everybody in, you know, being able to access the internet. I mean, you know, it's even more valuable during COVID, but it's a valuable form of, you know, maintaining contact with family, friends, and everything else, and professional services.
Yeah, it's increasingly striking how much you can't do if you haven't got the internet anywhere in the country.
It should be.
Then, sorry, I don't know how to pronounce your name. Is it Eleanor?
Yes, I just go by Lily.
Lily.
It's usually easier. Thank you. Really enjoyed both yours and sorry, I think I've frozen. The previous presentation as well. I am a trainee clinical psychologist at NHS Lanarkshire. Lanarkshire's pretty spread out, lots of rural areas. I have a client at the moment who doesn't have any service where he lives, so he needs the internet, but there's only one internet provider who will provide internet in that neck of the woods, and it's the most expensive one, of course. So digital exclusion is definitely something we've been thinking about a lot. My previous placement was with older adults, so a population who really struggle with the internet often anyways. But I think what's really struck me from what from both presentations so far is the way that our role has shifted towards very much a case manager and coordinator role. Often it feels like, because sometimes building on an existing relationship with somebody, or just actually you're the nice person who phones once a week, and it means that there's a lot of case coordination that happens because maybe we're a consistent presence that is sort of replies to phone calls or will call you back. And I know definitely I noticed that finding myself doing a lot more of the things that I used to do when I worked more of a social work setting, for example, as opposed to the counselling or the therapy that I would do pre-COVID or a bit later on in COVID. So I just sort of, I think my question is maybe around role delineation and how you've navigated that, because I think because our service took on a lot of that and was just like, well, we have to do it because that's what we're doing. There's been a bit of an expectation now of things as things are moving that we're going to continue to do that. So I've been asked to continue to do a lot of benefits stuff, for example, a lot of housing stuff that maybe is not really what my role is for, what I'm sort of paid to do. So I'm sort of wondering how you've been navigating those sort of different roles that people have taken on.
I was just going to say, I would think it wouldn't be such an issue for us, with Steve, because the people that the counsellors are working with are already within our support services, you know, so that stuff is being taken care of by the support staff in a residential project, or if they're in a providing support project and stuff. I mean, there has been probably through the pandemic, the counsellors doing a little bit more sort of, you know, like you say, keeping in touch, support type stuff, if you like, particularly with the floating support projects, maybe not so much of the residential projects. But I think we're fortunate in that regard with the network, in that because they're attached, you know, they're already Woolwich clients, we're sort of that those needs are being met, really. I don't know, maybe you can add to that, Steve. But
yeah, very much what Anthony just said. You know, they are very specific and defined roles. Yes, everybody's gone above and beyond in terms of the counsellor's remit and, you know, their kind of specification. There has been, you know, probably more, and it's just because these things have come to light and they're more prevalent throughout COVID. There have been more multi-agency kind of approaches in terms of people's mental health, you know, more liaison with GPs, CMHT and crisis teams. But yes, the support workers work therapeutically alongside the counselling process. So, you know, like I say, it's very, very much split, and everybody knows what they should be doing. So we've not put on we've not put anything more onto the counsellors' laps or workloads, as the case may be, because, you know, they're at capacity anyway at all times. So there is no movement to do that anyway. But yeah, support staff work therapeutically alongside that. So yeah, like Anthony says, all those things are already done, and the chances are they would have been done before counselling had begun.
Well, it sounds
Great.
like a great service. That
Yeah,
Yeah,
it's lovely to
Thank you.
hear there's that wraparound stuff, because I think, yeah.
Yeah.
Okay, brilliant. Thanks.
But it suddenly chimes with me, Lily, what you're saying. I think particularly at the beginning of the service of the pandemic, when we were still doing face to face, and we were sort of the only people who people would see, and then you ended up doing everything, as you say, because there was no one else to do it, and then that has sort of continued, and other people were very hard to get hold of sometimes, and so it was very hard to navigate, I think, for everyone. And I think it goes back to what Alex was saying earlier about you need to sort of watch that what you're doing is circumscribed and not ending up with the things that you've been doing in the pandemic kind of becoming the norm, and then thinking, oh, you don't need any other services because the CMHT is doing it all, or whoever it might be is taking on over all roles.
I think the majority of our CMHT nurses were redeployed during the pandemic as well. So sort of people juggling multiple caseloads. But I remember speaking to a CMHT nurse, and she was like, you're going to have to give me a minute because I've just come off shift and I'm doing 4 hours this morning to try and catch up with my entire caseload, essentially. So sort of feeling of, well, I can't help with being redeployed and in a ward, so I'm happy to do some of the extra phone calls to balance it out. But yeah, I guess as things shift.
Yeah, we just need to watch, I guess, that they don't shift too far and that they can go back again.
And the people
I think
don't
we'll
get
move
very...
on. Steve, thank you very much. I've just had an email saying how fascinating it was to hear about the system in Wales, because it is very different to us. You have to keep Wales open, because I meant to have a New Year holiday there in a few weeks, so I don't want you locking down.
Well, I can't promise anything, I'm afraid. I don't have that kind of authority here, Jackie. No, that was couldn't resist.
Well, I'm really looking forward to it, particularly hearing about what great services you have. So let's move on to Sophie Krenner, who I first met in, I think, 2006 when I was a junior doctor, and Sophie was a student OT in a homeless service in North London. And now Sophie is the Pathway Mental Health and OT Policy and Practice Lead. So that's fantastic, how life moves on. And Sophie, you're going to give us an update on inclusion health in the National Mental Health Standard Dataset. I've now reminded myself, sorry for not remembering earlier. So I'll pass over to you.
Okay, hi, my surname's pronounced Kerner, but that's okay.
Sorry, I did ask earlier and you weren't here and someone misinformed me, so I'm sorry about that.
That's okay. So I have been attending some of the mental health service dataset meetings, which is and they've been particularly part of trying to improve the quality of the data, and it's part of the NHS England and improvement kind of data improvement, and they want to make that the only collection set method for mental health services, learning disabilities and autism services. And as part of the advancing mental health equality strategy, sorry, I've made some notes which are they are trying to improve the data sets, in particular for people with protected characteristics and vulnerable groups, with the idea that you can improve the evidence base and the data collected, which then hopefully could lead to improving the care for those particular groups of people in a more targeted way. As part of the improvement process, they have been identifying, they've got 3 groups of priority. And in priority 1, they've got around sexual orientation, disability, ethnicity, gender identity, and accommodation status, particularly identifying it around homelessness and rough sleeping groups. But I think they maybe need to change the terminology there a little bit. And as part of that, these they're on version 5.0 of the data sets, and it was launched in October, I think, this year, the version 5, and I'm definitely sure it's for inpatient services, but I don't know. Jenny, do you know if it's being used in the community services as well? No. Okay, so at the moment they're working for adults mental health services, definitely inpatient. I believe it's going to community services, not IAPT though, because they collect their own data. And the idea is that they've kind of, as I've been part of contributing to creating some guidance around some of these areas, and obviously the accommodation status. And the idea for the guidance is to be able to help improve the way service users feel comfortable receiving these questions and being asked about it when they're first clerked into services, or as the, you know, kind of often these data sets are filled out, to help clinicians be able to actually feel comfortable and confident to ask about these protected characteristics. Because I know that sometimes often people just guess, and because they don't feel comfortable asking about it. Helping service providers think about how that's collected and whose responsibility it is to collect that data, and then other stakeholders and what they might do with that data collection and how it can be useful for them. And the guidance, particularly on homelessness or accommodation status, is asking, kind of gives a bit of a context of why it's important to ask, and what is a definition of homelessness. I'm just wondering whether it might be helpful to share that part of the document with you. Let me see. I've never actually had to share my screen before, so can you see that? Can anyone see that? I've lost everybody.
Not yet, sorry, Sophie.
You can see it? Is it?
No.
No. No. Okay. Right. Let me just see. How do I do that?
You click on the up arrow.
The up. I did click on that. Okay. Let me just try. There. Can you? Can you see it now?
No. We can now see your initials, not your face, which felt like something was changing, but not enough.
No. Okay. What I'll do then, am I back now? I will share it afterwards, the section of it, because that might be helpful. The one thing that I did want to share is that it's actually, so they've got about definitions of homelessness. This is a working document, so it's kind of only a draft at the moment, and there's the final version they're kind of working towards in the next month, a few weeks, I think. They ask how to ask about accommodation status, and then there's about 20 different housing accommodation categories now, which is quite a lot, but they are based on the ones that that Pathway, so Sam Dorney-Smith, along with a few other people, did develop with Jill Leng, and I can share that document. But the issue is that came up with the kind of the last kind of iteration of it is that whether people understand what each of those accommodation statuses actually means, because it's only helpful if you're collecting the appropriate accommodation status for people, and potentially having too many may create more confusion, and it's hard to know. But I don't know whether these categories have actually been piloted, or whether actually they only started collecting this data in October. So it might be that actually we're waiting for the live data to come through before it can be really seen how helpful they are. But that was kind of the discussions that we've had so far, and whether the service users, so for example, their concern was lots of people. Oh, sorry, my camera does it. Is that back on? Thank you.
Yes.
Lots of people. Yeah, that's better. Okay. So one of the concerns is that people might have a different definition of what a hostel is, and how do you make sure that everybody is using the same definition for that? I'm not sure that, as long as it's kind of capturing the data at this point, I'm not sure whether that needs to be refined, but the guidance might help or not help with those kind of things. So that's just a very whistle-stop kind of
well, it sounds good that the data's being collected.
Absolutely. And I think, I mean, they've only got a couple of months so far, so I think it will take a little while to actually see how well it's being recorded and what can actually be done with that data. That's the bit I'm not quite sure of at the moment.
It always feels like there's a balance between, as you say, like if people are interpreting hostels slightly differently, you don't want to get too bogged down in that, I would say, because the important thing is getting some information and then sort of worrying about that later. I think you can tie yourself up in knots a bit. Did you say there's 20 categories for?
Yes, there
are.
So it goes all the way through from how, you know, the various different housed, so owner occupied, through to care homes and those kind of things, supported accommodation, rough sleeper, squatting, sofa surfing, staying with friends and family, B&B accommodation, sleeping in a night shelter, hostels, temporary housing, and then the other ones are kind of admitted to hospital. So it does have a range, but there are a lot of categories. I suppose that reflects that there are a lot of different places that people are staying, and that's part of it. But will it lose some of it by having so many? I don't know.
Yeah, well, I suppose it could be refined as it goes along. You need to make it so it's sort of people do it, don't you? I can see that Sam has joined us. Hello,
Yeah.
Sam, and has her hand up, a real life hand rather than a.
I have.
hand.
I'm just wondering whether I can share, because I think I probably can share.
Okay.
Like what I think is the.
Oh, wow.
Is it this
Look
one?
at this.
Yes. Or
Okay.
it's basically that one with a.
So this is a list. The reason why this list of codes was chosen at the time was because, I mean, people may be aware of the planned migration to SNOMED in terms of clinical coding for all of the systems. So this was the perceived best set of clinical codes that was available on SNOMED. It's quite hard to actually request new codes on SNOMED. You have to have like a panel, you have to have a really good argument for doing it. So this was the list, and I don't know how much it's been edited, but we did try at the time. So it was a group of people from Crisis Shelter, MHCLG, to come up with a list that we thought was as clear as possible. I don't know whether people can read that as they're going down. I'm not going to read every single one out, but most of them, I mean, I would agree that temporary housing could be misinterpreted. We did consider going through things like bowel hostel, refuge and stuff like that and whatever. If you do all of that, it comes to something like 32. So, but they are all there and they could be put in. But yeah, so this is the list. I mean, we could possibly distribute the list to the group. Has anybody got any questions on that? Can they see it? And is there any immediate questions?
I suppose we all work within homelessness, and so we kind of understand those more kind of specific titles and things. But I suppose if you're a nurse working on a community team or a ward and you don't understand those, would you be able to fill it in?
So we do have some some suggestion that people aren't very good, I mean, don't understand it terribly well, because the emergency care data set does have a drop down of housing status fields currently for use by A&E receptionists, and there is guidance along with that, and we can see it's not being used terribly well. People tend to default to the one at the top of the list, but then we don't know necessarily why that is, because that hasn't been fully unpicked, whether it's people that don't understand it or whether they just, it could be literally they don't have the time. We don't know what the reason is, but certainly they're not finding it really easy to use well. But I don't know about Jenny, but I don't, because your current list of housing fields on the mental health accommodation data set, which is 34, that's also, we know, not used terribly well.
So I suppose now it's become a mandatory field. I don't know whether that will make a difference. And then I suppose then it can be actually trusts services can kind of put in a bit more kind of emphasis on actually filling it in properly. But I don't know.
Yeah,
let's hope so. It's a start, isn't it? So I mean,
Yeah.
it's really good that it's a protected characteristic apart from anything else. And I think people maybe do have a tendency just to tick a box to say that it's completed, but we can look at it. And Nigel, your hands up. Sorry. So
I was going to say, potentially, if they can work out guidance that works and people are using it, then mental health kind of leading the way with that for other services.
Yeah.
So yeah, I just wanted to put this in a national context. So for people who don't work directly for the NHS, you might be naturally assuming the NHS knows how many homeless patients it has, but it doesn't. And the other assumption you may have is that the mental health data set would be the same as the emergency department data set, would be the same as the GP data set and the admitted medical patients data set, and they're not, and they're all different, and they all use different codes, and it's a complete dog's breakfast. But this move to SNOMED should mean that if you mark somebody as a rough sleeper in any of those contexts, it ought to map across. And this has huge potential to be really powerful, because if you could correlate people's housing status to their clinical conditions and their multimorbidity, we'd be able to demonstrate some of the particular impacts of those social deprivations. So, and there is a sort of growing understanding of this. So it's great that the mental health services are catching on to this. And the Office for Health Improvement and Disparities, Inês Campos Mantos, Inclusion Health lead, has caught onto this as well. And I think I've just put her in touch with you, Sophie, to see if we can get that linked up. So there is a lot of potential in all of this for making this group really visible. So I suppose my feeling is that almost kind of any data is probably better than none. So even if it's initially not great quality, if we can just, because, you know, particularly if we suddenly apparently have hundreds of thousands of rough sleepers, then the system is going to wake up to that and try and do it better, because it's going to, you know, it's going to distort everything.
Yeah, that's a good point. So I mean, it would be good to have sort of something to triangulate other figures about rough sleepers with, wouldn't it? And then you can think, why is this different? And is it data collection, or is something else wrong? So I think it's an excellent start, and good to hear about. Thank you, Sophie. Alex has got his hand up. Alex.
Sophie, actually, just a question. I didn't really catch it. When they say they're going to mandate it, did you get a feeling to what does that mean? And are they going, will they release, so they're working on guidance, does it mean, did you have confidence that that mandate would be enforced, if you like? So, or is it something that they'll put on a website and then or are they actually going to change the systems, make the fields things you can't get past until you've filled in? So will it be aggressively mandated?
That's my understanding, that they will be mandatory to fill in order to be able to kind of complete the forms. So hopefully, yeah. So there should be some information. Whether it's correct and accurate will be the next step, but there should be some information that is collected.
Very good.
Okay, thank you, Sophie. If there aren't any questions, we'll any more questions? Anyone? We'll move on. The next thing is it says information sharing and updates on other services. I don't know if anyone has any updates to tell us about. My update is that I'm very busy. Our service seems to be very busy. I imagine it's the same everywhere. We seem to be having more referrals of people sleeping out. We've still got people in hotels, and everybody seems to be having more mental health problems, which is making life challenging. So it's nice to have a morning of reflection. How are things elsewhere? If nobody wants to say. Alex, is that a legacy hand, Alex?
Well, I've got a couple of other things to share, I guess, which are more kind of general updates from Pathway. But
yes, please go ahead. And if anyone, just going to say, if anyone would like to say anything, if you put your hands up or say in the chat, and Alex, if you could update us, that would be great.
So I've posted in the chat just the program, a link to the program for our conference next March. So please do check that out. It's more or less complete, but still a few tweaks, but excellent 2 days, and we're very bravely, we'll see what happens. We're currently planning to be in Manchester and to be in London in physical venues. So do come to the one nearest you if you can. COVID may, of course, intervene, and we have the technology to go all back online if we have to, but we're hoping that there can be some chance for people, as we were talking earlier about the value of those small micro communications. It would be really nice to have people in the room together to get the feelings, as our counselling colleagues talked about. So that's to share that, and some other work I just thought people would be interested in, that we are involved with Crisis now, looking at trying to influence the new Health and Social Care Act. I'm not sure this is relevant for Welsh colleagues, but be very interested in I mean, in a way, we're now really interested in the differences between the different nations and how approaches work. But so the new Health and Social Care Bill, as it is currently, sets up the integrated care systems as they're supposed to be, and sets out their mandates and their roles and their functions, and integrated care partnerships and integrated care boards that I'm now learning about. We have proposed with Crisis an amendment to the Act as it goes through Parliament to try and get inclusion health groups named on the face of the bill. I think where we've currently got is as a duty for the integrated care boards to think about inclusion health groups as they create, and they're mandated to create a strategy. Some discussions about whether that's the right place or level at which to put it. And we also expect some pushback from the Department of Health and government, who are already slightly saying there are some broad health inequalities duties in the Act, and you guys don't need anything special. So we're working on our arguments as to why inclusion health groups do need extra special attention, and that's currently in progress. It gets to second reading, it gets to committee stage in the House of Lords, which is where we're going to push an amendment, I think in the third week of January. And yeah, interesting time. So two things just to share. If anyone knows a friendly member of the House of Lords, drop me an email, because we've got material to send them.
I might be able to help with that. I did meet someone in the House of Lords the other day, interestingly.
Well, excellent.
That's the social circles I move in. I'll let you know afterwards.
So you're not someone you picked up off the street, I'm guessing.
Governor at my kid's school, interestingly. So.
Interesting.
No, not someone I met at work. No. Great to hear that it's going to be a real live conference next year. Very excited.
And the other thing, so we're very excited about that. Hopefully that comes off. The other thing, back to the amendment, is working with Crisis, and we've begun to set up a network with other charities nationally to try and slightly, if you like, make sure that we're making a bit of a noise about homelessness in January. I mean, there often is quite a lot of media, but so that it's current, and that perhaps turns up some of the pressure in Parliament. And again, crisis policy colleagues are looking for any big studies or stories or things people might be aware of are going to be released in the period after Christmas, that we can make a kind of catalogue of them and help maximise the kind of coverage and the noise around these issues during that period. So just to share, if anyone's aware of a great publication or research study or something which might be coming out after Christmas, we're very keen to capture that. I think, again, colleagues in Wales and Scotland, we're very interested, again, to make the case that things are different in other parts of the UK. That can also help us make some of these arguments. If we can say, well, look, up in Scotland, they're doing it like this, and that's helping. So those were my two updates. Jenny, have we lost you? Jenny seems to have frozen. Are you there, Jenny? I think
the Wi-Fi's gone in South London, isn't it? Yeah.
I attend quite a lot of forums.
I think she may have. Yeah, I think we've
about pie and working a lot of stuff with Robin Johnson. We do his forums quite often, and he often says that he's quite hopeful that the much more joined up approach that we've got in Wales and Scotland, that things can be done a little bit differently, and he often talks about the sort of disparate the way it is in England, sort of thing. So it's good if you've got a chance to be all singing from the same hymn sheet there with what you're doing going forward.
Thank you. Well, we'll keep plugging away at that. I think we have seem to have completely lost our chair.
Well, I think we're probably at the point of wrapping up now, anyway, aren't we? Because we've had all of our presentations. We've just been discussing in the chat the challenges we had with letting people know about this meeting, and I think we I don't think we've had as many people attending as we would previously have done, and we will reflect on that and do it better next time. But thanks to the speakers for consenting to sharing the recording. So what we'll do is to widen the access. We'll put out to the whole mental health group a link to this recording once we've tidied it up, so that we can ensure that as many people as possible have the opportunity to hear what's been said, and then we'll learn from this in the future to get the message out earlier in anticipation of the meeting, and send out a diary invite too.
Okay, great. Thanks, everyone. and we're giving people a bit of time back in your days. And thanks. Very good to meet you, Steve and Anthony, and perhaps we might follow up offline.
Likewise. Yeah, much
Yeah,
appreciated.
thanks for the invite.
again.
Thank you.
Fantastic.
Bye.
Thanks a lot.
Cheers.
Bye.
Bye. Bye.